Let's talk about the relationship between sensitivity and specificity. The board exam loves to test you on the double hump graph, which shows the correlation of sensitivity and specificity. Remember, in medicine, there's no perfect test. But let's take a look at the graphical representation of ordinary test that is either specific or sensitive. So here at the top part is the number of patients, and at the bottom here is the number or the specificity or sensitivity of the test. So the first hump says if a test is less than 50% on the left hand side, they don't have the disease. If it's greater than 50%, they have the disease. Wouldn't it be great to have a test like that? Hey. Oh, I see you taking a lot of notes while you're watching my YouTube video. I hope you're enjoying it. But there's only one problem. First, you've been watching all my lecture video content for free, but only 52% of people who are actually watching my YouTube channel have actually subscribed. Now, the other 48%, you might be one of them, but I'm not sure, so I'm not gonna judge. But can you do me just one favor? My goal in this channel is to bring you more content every single time so that you can have access to free quality education. However, in order for my videos to help millions of people around the world, I just need a favor. Can you help me get the number of that 48%? We can get it down so that we can get more subscribers to this channel so we can help millions of people around the world. So do me a favor, smash that like, subscribe button and share my videos to your friends and comment below, all right? I really appreciate you. And just because you have decided to do that, I promise you I'll make more videos. Thank you. You rock, you're awesome. All right, do me a favor, just smash that like and subscribe and then also share my video to the rest of the world. I appreciate you so much for helping me grow my channel. God bless you. Have a good one. All right. Okay. Now, you can go back to taking your notes inside my lecture because the rest of this lecture is going to be amazing. So you don't want to miss it. Let's continue. Oh, one more thing. I almost forgot. Yes. What I told you. You haven't done it yet. I can tell. Just smash the like and subscribe button and subscribe to my channel. Thank you. You rock. But that test does not exist, right? In real life, most tests overlap. And this is what we typically see. You see an overlap between patients that have the disease, okay? And you see this is what you are going to see in the real world. You're going to see an overlap with a test that's going to be able to pick up some patients that have the disease and miss patients that don't have the disease, okay? So on the left side is the people that do not have the disease, okay? So let's write no disease and have or positive for the disease. So often, let's say you draw a threshold here that you say, hey, at 50, that is my cutoff point. And usually on the board, what they want to test you on is which part of this graph is where you get the most sensitivity or the most specificity. Okay, so let's start with the black line. The black line says no disease, right? Now, no disease is going to test the true negative. Let's draw out our 2x2 table so we can see this in the table representation. Remember, in that table we said we're going to order a test, and the test can be either positive or negative. And you can either have the disease, test positive for disease, or test negative for the disease. True positive, true negative, false positive, and false negative. So when we order a test, right, and patients test negative for the disease, hey, before we continue the lecture, I have a bad headache. Yes, I do have a headache. And if I have a worst headache of my life, I know on the board exam, you know what that means. Oh, wait a minute. Maybe you don't know? Oh, okay. If you're taking the USMLE and you struggle with neurology concepts, for example, multiple sclerosis, do you know those dorsal column I can never pronounce the word, lemniscus? Yes, that's the word. Pathway and those spinocerebellar tracts and lateral corticospinal tracts. Oh, so annoying. I know. But the USMLE loves them. Okay, so here's the deal. If you find yourself struggling with any neuroscience concepts, all right, I have something special for you. Now, this neuroscience concept is something that a lot of students do tend to struggle with. And if you're not one of them, that's fine. You can continue watching the video. But if you do struggle with neurology, I've got something amazing that you are going to love. I have a free USMLE masterclass where I break down neurology concepts. Yes. It also comes with a neurology workbook. Inside this workbook, I show you the exact strategies that I use to teach neurology and how I personally know how to study neurology. How I'm able to differentiate between, ischemic stroke from hemorrhagic stroke, multiple sclerosis, Guillain-Barré, and the list goes on and on. It's so easy, I know. But if you want to learn my secret of how I actually able to keep all this information in my head, I got a 99% on my board exam, match into emergency medicine residency, and now I'm a board certified physician for over 15 years. Hey, listen, do me a favor, click the link below. There's a link inside the comment section. Grab my free neurology workbook and register for free for my masterclass. And you're gonna get instant access to my free training on neurology concepts. Listen, this is not for everyone. If you don't struggle with neurology, don't waste your time. Just continue watching the lecture video. But if you do need help, register. It's free, all right? I'll see you inside the masterclass. And thank you for watching my lectures, and let's get back to our lecture.
Well, I actually started being interested in medicine watching MASH with my parents every night after dinner, watching Hawkeye, triage patients, see what needed to be done for them, who needed surgery, who didn't, and that kind of made me interested in medicine. So went out, actually joined the military, was a military medic in the Canadian Army for a few years. And then got into nursing, took my nursing degree, ended up working a mix of medicine, inpatient psychiatry, and then I found my true home in intensive care. And then my husband said, would you stop talking about medicine and just do it already? So I went to med school, got into the Caribbean, St. James School of Medicine. Well, I have worked clinically for so long. So sometimes, following a textbook versus following, what I've done in practice as a nurse, sometimes would collide in my brain a little bit. So I would be like, well, I obviously have to do this first because I can't, do this yet. So I really had to retrain my brain to figure out what I should do in terms of best practice, in terms of, evidence-based medicine, especially in the United States. I'm Canadian, I train in the Canadian system. So I used SMASH actually for step 2 CK, which was one of my better ideas, I will say, because the videos helped me understand from the ground up, and I was able to apply what I was learning, what I was understanding, and then actually be able to think through the questions that I was working through. I love that it wasn't just a slideshow or a video saying, this is this is that, the passion to teach came through across the video, and I was able to actually put it together. It engaged my brain to be like, oh, okay, well, this is how this works. It was like a continual light bulb moment every time that I watched these videos. And I mean, it's tough if you're watching a lecture that someone doesn't have that kind of drive to kind of pull you in and get down to your level and be like, hey, this is what you need to know, and this is how you best need to learn it, and then this is how you apply it. So I mean, that's what I loved about it, instead of just a PowerPoint which I could read by myself without being taught. So step 1, I actually scored a 222. So I took a few months off after finishing on the island, studied for a bit, figured I had things sort of handled, took the exam, got my score, and continued on into clerkships. And then went through pretty much all of my clerkships before I was able to nail down getting through CK, especially when the pandemic hit. I was working in ICU and trying to study at the same time. And I'm like, you know what? I need a little bit of help with this. So watch the videos to try and shore up my knowledge, because I didn't really have a lot of time to study, or a great time frame, because I needed my score before match. So it was quite the push. Scored a 233 on CK, which I don't think I would have gotten without some of the videos, because like I said, I didn't have a lot of time. I was full of tons of doubts. I was really unsure about what I was aiming for. I didn't know if I was going to make it. I mean, I needed a visa sponsorship as well. And, you know, with border restrictions and the uncertainty of the J1 visa, I didn't even know if that was going to be possible this year. So like between my scores, being Canadian, being an IMG, I was like, I'm really aiming for the stars here, but I'm going to go for it. Yeah, it's been a wild ride to get here and to match finally. I matched at Louisiana State University in their combined internal medicine, emergency medicine program. Keep studying, keep working hard, put yourself out there, get networking, because even though it feels like everything is against you, you know, it is possible. You are able to do this. Put in the time, put in the work, and then one day in a couple of years, you're going to be in the same position we are, and you're going to guide the next group that comes through, and you can tell your story and show how you did it as well.
The test is negative and they don't have the disease. This is the no disease aspect. This graph represents true negatives. Let me highlight the true negative so we can follow the graph. True negative basically goes all the way down. But you can see we are crossing into the disease area, okay? So all this area here is the test being true negative, okay? For the black line. However, as you can see here, we have some patients that have the disease, right? But they are testing negative for the disease, right? So this area of the graph is the false positive. Okay, they have the false positive. Let's use a different color. False positive. False positive, they are testing positive for the disease. See how we are now in the red zone, but they don't have the disease. Remember? This is the line we are looking at. They don't have the disease, but they are testing positive for the disease. All right? Now let's take a look at the second graph, which is telling us the patients that have the disease. Right here, we're on this column right now. We've talked about that column. On this column, we said patients that have a disease, right? Great. We trace them all the way down. Okay? And we get to this branching point, and this graph represents all the patients that do have disease and test positive for the disease. This is the true positive. Great test. But then it overlaps, and when it overlaps, we get some false negatives. Okay? Some false negatives here. In the false negative area, what happened? The patient is testing negative for the disease, as here, but they do have the disease, right? They have the disease, but they're testing negative. That is a false negative rate. So let's put this in purple, false negative, and put our false positive in blue. Okay? So now you can see on the graph, the purple goes here, okay? Let's use red so these color combinations can match. True positive, this is our true positive. And our true negative, which is in black. So this exact 2x2 table is what you're looking at here on the double hump graph. Now, the board would like you to know about what happens when we try to increase the sensitivity or increase the specificity of a diagnostic test. What is the definition of sensitivity? It's the proportion of all people with the disease who test positive for the disease. let's go back to the graph. This graph right here in red are the people who test positive for the disease and have the disease, okay? And it goes all the way down here. So if you just look at the red line, if I want to so here is where my sensitivity is, okay? Let's call that A. Now, if I want to improve my sensitivity of this test, I can take this red line and move it backwards and bring it all the way here, which means the graph is going to look something like this. Let's draw this line, and this is my red line. If I bring the line backwards here, okay, closer to 0, I'm going to increase my sensitivity, right? That's what's going to happen. I'm going to increase my sensitivity, and what's going to happen to my false negative rate? My false negative rate is going to be lower by increasing and moving, drawing the line towards the left side of the board. That's increasing sensitivity. That will be a great test because now all the proportion of people that test positive for the disease are going to have the disease, okay? But if I keep increasing this all the way, basically what I'm saying is if you show up at the door, I don't have to do the test. I can say, listen, you have the disease, you have test positive for the disease, okay? So that is where 100, so if we move the graph all the way towards the end here, we have 100% sensitivity, okay? Now let's take a look at the black graph. The black graph is the true negative, the proportion of people without the disease who test negative, right? So if we look at the graph of specificity, it goes all the way, keep going, keep going, keep going, all the way here, right there. So if I want to determine 100% of my specificity, this is where I'm going to push my graph. So I can push it forward. If I keep pushing it forward to the edge of the limit, which means if I keep increasing the specificity, what's going to happen? This is the specific section, right? We have true negative. I keep decreasing my false positive rate. This is my false positive rate. I'm going to lose a lot of my false positive rate and keep dragging the graph all the way down, increasing the specificity, will cause me to have more and more 100% specificity. So on the graph, on the boards, what they'll do is they'll draw the graph, they'll label A, let's put this C, A, B, and C. And they'll tell you if they move the graph towards the left, towards the left side of the board, okay, which of the following parameters will be affected? Specificity, sensitivity, positive predictive value, negative predictive value, and the answer is sensitivity. As you can see, this side is the people with the disease, and that side is side without people without the disease. Important. If they move the graph if they tell you they move the line from A to C, they're moving this direction. Remember, if we're moving in that direction, we're going towards the people without the disease, right? That means our true negative is going to be approaching 100%, which means we are going to increase specificity. Now, the line that bisects both lines here at 50 basically is the practical compromise between specificity and sensitivity. Why? Because that's the line where you have the false negatives and the false positive, which is usually what happens in any diagnosis test. You're going to get a little bit of false positive and a little bit of false negative. So that's what they want you to know. So remember, A side, highly sensitive at 100%, okay? And the C side, highly specific for patients that are not testing for the disease because they test negative for the disease and they don't have the disease. So what is the case in point? The point of a specific sensitive test is to find a diagnosis. We want to know if you have a disease. So if I create a test that is highly sensitive because missing the disease is going to be bad. For example, if a patient has a pulmonary embolism and I order a test
and the test misses that, the patient can die, right? If I order a troponin test and the patient has myocardial infarction and the test misses that diagnosis, missing the diagnosis is bad. That's why we want a highly sensitive test. So it's becoming nice to know that a patient has a positive test and they do have the disease, okay? Now the same thing applies to specificity. In specificity, it's more important to find out of people who do not have the disease, because if I have a high false negative rate, right? Because of a high false negative rate, which means sending patients with disease home is not a good idea, right? So if patients really truly have the disease, you do not want to miss the fact that they do have it. If you send them home, they can go home. Which means if you send a patient home that do truly have the disease, they can die, okay? That is the relationship between sensitivity and specificity in a graphical double hump representation.
Thank you for watching this lecture video. I hope you enjoyed it. I would like to hear your thoughts in the comment section below about what you think about this lecture. And also, if you want to watch more lecture videos like this, click right here to watch more lecture videos like this. And don't forget to like and subscribe. You rock.